Thank you for joining us today. The Indiana Hospital Association. My name is Rebecca Hancock. I'm a Patient Safety and Quality Advisor in the Patient Safety Center of the Indiana Hospital Association. Today, we are doing a podcast on the treatment of pediatric sepsis, and we're fortunate to have Dr. Tyler Arnold joining us today. Dr. Arnold is the Assistant Medical Director at Riley Hospital Emergency Department and the Assistant Professor of Clinical Emergency Medicine and Pediatrics at Indiana University School of Medicine, and we're so fortunate to have him here to help us determine the special needs of pediatric patients in the treatment of sepsis. Dr. Arnold.
All right. Well, thank you, Rebecca, for having me on this podcast. I welcome the opportunity to speak about pediatric sepsis treatment. So I'm pretty lucky that I did not have the recognition topic, as Dr. Wagers had already discussed earlier. That is a far more difficult topic to cover, especially since we see so many febrile illnesses in the pediatric sepsis population. So really I'm going to focus on discussing the treatment of pediatric sepsis. So I am a trained pediatric emergency medicine physician, and I try to boil problems down to their simplest parts. Really the hallmark of pediatric sepsis treatment is fairly simple in theory, and that's one, to give antibiotics, and two, to reverse shock. This really isn't that much different than treatment in adult sepsis patients, but there are some physiological differences that we'll talk about in just a moment that do make this a little bit more of a challenging topic. We do know that giving antibiotics early on in sepsis is very critical, as each hour delay in antibiotics is associated with an increased mortality. Now, there is some controversy on whether to give antibiotics within a 1 hour window or a 3 hour window, but the data does suggest that 1 hour is probably a little better than the 3 hour, but the earlier you get antibiotics into a septic pediatric patient, the better they're going to do. Also, with respect to reversing shock, in children treated in the community setting, each additional hour of persistent shock was associated with a greater than twofold increase in mortality. And we defined persistent shock as abnormalities in the capillary refill or the age-adjusted blood pressure. With respect to giving antibiotics early, this really is not that much different than the adult sepsis treatment. We tend to give broader antibiotics in the beginning because in the emergency department, we don't know what we're treating oftentimes. And again, the goal is to give that within the 1 hour. We typically use a third or fourth generation cephalosporin plus vancomycin. For certain populations of patients, we do add anti-pseudomonal coverage, that being the immunocompromised, such as undergoing active chemotherapy or burn patients. In the pediatric population, we also have a specific population of patients less than 3 months of age who get different infections, including E. coli, Listeria, and Group B streptococcus. In those populations of patients, we tend to give ampicillin, gentamicin, plus acyclovir to cover for HSV in those patients younger than 3 weeks of age. In the older patients, from 1 month to 3 months of age, we typically focus on ampicillin and a third-generation cephalosporin. With respect to reversing shock, there are some key physiological differences, as I alluded to earlier, that can be a little trickier in treating the pediatric patients because pediatric patients have more abnormalities in vasoregulation and myocardial dysfunction compared to the adult populations. So pediatric patients get a couple of different shock states. One of those is warm shock, which is defined as increased cardiac output and decreased systemic venous resistance, or cold shock, which can either be a decrease in cardiac output plus with an increased systemic venous resistance, or an increased cardiac output and an increased systemic vascular resistance. These key differences in presentation will really help us determine what kind of inotropic support these patients may need. A second key difference is that pediatric patients are more likely to develop respiratory collapse, especially in the younger patients. In children with severe respiratory distress with sepsis and shock, a significant proportion, up to 40%, of their cardiac output may be devoted to their respiratory system. So intubation alone can reverse the shock in these patients. I don't advocate for intubation for every patient with sepsis, but it should be a strong consideration, especially those in severe respiratory distress. A third difference in the pediatric population is that they have an increased resting heart rate and less cardiac reserve, especially in the younger patients. Cardiac output is much more determined by your heart rate the younger you are, whereas in older patients, they tend to augment their cardiac output by augmenting their inotropy, or the squeeze of each heartbeat. Other key differences are that pediatric patients are more likely to be hypoglycemic and hypocalcemic, and more likely to present in disseminated intravascular coagulation. So that leads kind of to the question, well, how do we reverse shock once we have identified it in a pediatric sepsis patient? The first step in this is to provide oxygen, because shock is defined as an abnormality in oxygenation of tissue. The second thing we want to do, and we want to do it within 5 minutes of recognizing sepsis, is establish IV access. Our options are generally a peripheral IV, and we definitely want to get 2 points of access in these patients to, 1, fluid resuscitate, and 2, to give antibiotics very quickly. The challenge, though, is that peripheral IVs are oftentimes very difficult to get, especially in babies who have sepsis and who may also have hypovolemia. We definitely advocate for early intraosseous access in these patients. It's readily available and easy to obtain. The challenge is always in those patients who you think may have sepsis, but you aren't quite sure of the diagnosis. You may need supplemental laboratory studies to make the diagnosis. A third option is central line and an umbilical line, but these procedures oftentimes take a while to set up. When we're getting labs, we oftentimes want to also get a laboratory evaluation. So pertinent laboratories in the pediatric population do not differ that much from the adult population. We definitely want to get a blood gas, a lactate, CBC, a CMP with hepatic function panel, coagulation studies and fibrinogen, a blood gas, ionized calcium. You also want to identify the source. So if you have a strong suspicion of a urinary tract infection, you definitely want to get urine cultures and urine studies. And if you think the patient has meningitis, you want to get CSF studies and cultures. I should note that you do not want to delay antimicrobial therapy if you believe that a patient has sepsis from meningitis. The third step in reversing shock, and this is the same for warm shock or cold shock, is fluid resuscitation. We typically start fluid resuscitation by giving 20 ml per kilo of crystalloid solution, so either normal saline or lactated ringers, up to 60 ml per kilo in rapid boluses. And when we give rapid boluses, we generally talk about push-pull method, or a pressure bag, or a rapid infuser. Gravity alone and running fluid boluses over the pump does not get the fluid in fast enough. In between boluses, we want to reassess in between and stop if signs of fluid overload develop, including RALS or hepatomegaly. If the shock does persist, we generally advocate for starting vasopressor therapy. This is where the physiological state of cold shock and warm shock come into play. In cold shock patients, so those patients with increased systemic venous resistance, they present with cool extremities, thready pulses, and delayed capillary refill. We generally advocate for starting epinephrine, and the dose of that is 0.05 to 0.3 micrograms per kilo per minute, titrating up to a dose of 1 microgram per kilo per minute. Dopamine can also be used, but there's some new data that indicates that dopamine is probably inferior to epinephrine. In warm shock, those patients with decreased systemic venous resistance, we want to start norepinephrine at 0.05 mics per kilo per minute, and titrating to a dose of up to 2 micrograms per kilo per minute. In catecholamine-resistant shock, you want to consider treatment with steroids early, especially in those patients with chronic steroid use, hypothalamic pituitary or adrenal disorders, or purpura fulminans. You also want to pay attention to treating hypoglycemia and hypocalcemia, as I mentioned earlier, as this will increase morbidity if these are left untreated. We also advocate for giving blood products as needed. So our goal for our hemoglobin is generally greater than 10 grams per deciliter, platelets greater than 50,000, and fresh frozen plasma for active bleeding, purpurifulminans, or an increased INR.
Is there a way to address the opportunity for transitions in care from transferring? What are the primary steps to get done if the patient needs to be transferred? Do you do any work with that regarding rural critical access transfers? So when would be an appropriate time for patients to be more likely to be transferred than treated in the ED in some of our community hospitals?
Absolutely. So I think if a patient has persistent shock, or if they do not respond to inotropic therapy and need ICU care, then they need to be transferred to a place that does have a pediatric intensive care unit. If patients are getting to their third fluid bolus, or up to 60 mLs per kilo of IV fluids, they need to be in a hospital where they can be monitored on a pediatrics floor at the minimum.
And what I understood you saying, primary treatment for oxygenation and 2 IV access sites if possible prior to beginning the fluid. So if that can be done, I would think that would be a good first step prior to transfer.
Yep. So the biggest thing is to establish IV access, give antibiotics, and start the fluid resuscitation. After that, if patients need inotropic support, they should start inotropic support, but they should not delay giving that prior to transport. If they are on inotropic support, they need to be in a pediatric intensive care unit.
Thank you, Dr. Arnold. That was a tremendous detailed presentation of the needs of the pediatric septic shock patient, with the similarities between peds and adults with antibiotics and reversing the shock. Of course, with some age-adjusted differences in the treatment modalities that you're going to give and the expectations of different levels, such as a closer examination of glucose and calcium levels and hemoglobin that is specifically referred to in the adult sepsis guidelines. So I hope that this has given a little bit of information for our hospitals across the state. I know it's a very detailed approach, but we need this clinical understanding of what's going on with the pediatric patients in order to meet that 1-hour antibiotic administration time goal that you've stated, and to adequately address the pediatric patients across the state. So I thank you very much for this content, and I think that we will probably create a lot of opportunities for improving pediatric care across the state with this general understanding between the sepsis presentation and sepsis treatment that you and Dr. Wagers have provided for us. Thank you.
Thank you.